Good evening. This is the start of the cardiovascular and peripheral vascular examination. I have the patient here in front of me. I'm going to start by washing my hands at this time. Okay. My hands are clean before I start touching the patient. Good evening. My name is Shayna Mitchell. I'll be your nurse practitioner for this evening. We're going to note the patient's general appearance, non-ill looking, very kept appearance. There's no nasal drainage, ear drainage, or drainage from the patient's sclera at this time. The patient does not have any physical Lewy body movements or tremors. If I were to have a vitals machine, I would then take the patient's vitals and assess within normal limits blood pressure, temperature, respirations, which can be known that the patient's respirations right now are about 16 to 17 breaths per minute. And then I would be able to palpate manually on the patient's radial arm from the thumb all the way down side with my 2 index fingers. So the patient's radial pulse is not pulsating abnormally. It is a very rhythmic pulse, and I'm going to assess it bilaterally just to make sure. Next, for the inspection, I'm going to inspect the patient for any jugular venous pressure or distension, any carotid pulsation. And so basically, I'm just taking a look at the patient from each side. At this time, I do not see any jugular venous distension. At the patient's jugular vein, the carotid artery is able to be palpable. I'm also going to note that for additional inspection, I'm getting ready to notate the maximal impulse and inspect for abdominal pulsations. Now, I can't do it fully right now because the patient is in clothing, but however, if the patient was in an actual clinic or in the hospital, the patient would have a gown on and I would be able to see the patient's anterior chest that would be exposed. For palpation, the ruler of notation is actually placed vertically at the sternal angle, and another straight object is placed at a right angle so that the lower edge would rest at the top. So basically, I would be going in with both my 2 fingers and just kind of assessing. Patient has a very strong pulse. I'm also getting ready to assess for the amplitude of the carotid pulse. I didn't feel any thrills. I'm going to use the Brewy side of my stethoscope just to listen. The amplitude of the patient's carotid pulse is clear. I don't hear I hear a Brewy, and I don't hear any non-whooshing sounds or any forceful blood flow sounds in the patient's carotid area. Next, as far as wanting to assess the abdominal area for maximal pulse impulse, you would palpate at the mid-clavicular line at the level of the fourth and fifth intercostal space. That would be just below the nipple area here and all the way around to the back of, let's say if we had a female of a patient's bra line. We would just feel the impulse with one fingertip, and if not felt, like if the patient were supine, then we would have him lay on the left lateral side in the decubitus position. The same would be at the palpation for the left sternal border and the third and fifth intercostal spaces. We will be assessing the systolic impulse of the right ventricle. So let's go ahead and assess that. I hear a S1 lub dub sound. S1 and S2. Next, we would palpate the pulmonic area, the left second intercostal space, to assess the pulmonic artery impulse. This would be the left edge of the sternum, about 2 inches inferior to the clavicle. Go ahead, take a deep breath in. Again. 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 The next area of palpation will be the aortic area. There will be the right second intercostal space, which we also just did in full assessment. To assess the aortic arch for pulsations, that would be on the right edge of the sternum, about 2 inches inferior to the clavicle. As far as percussion, we did use our stethoscope to percuss on the left border to assess any cardiac dullness, or if the maximal pulse impulse is not palpable. We would percuss medially from an area of resonance that would be left of the midclavicular line to the start of the cardiac dullness. So now, even though we use our stethoscope and we auscultated our carotid arteries for any bruits, I'm also going to assess one more time and ask the patient to hold in his breath. I'm going to use the diaphragm side and the aortic and pulmonic areas, and then at the apex, and then finish at the fourth and fifth intercostal space. Go ahead and hold your breath for me. Okay. This concludes the ending for our cardiovascular assessment. No murmur was detected. The timing for the patient's S1 and S2 is within normal limits. They're exactly 60 to 70 beats per minute. Additionally, if I were to have a vital signs, a Dynamap, I will be able to assess that. So this concludes the end of the exam. And I just want to make one last notation for our peripheral vascular access. We did assess the patient's radial pulses. Thank you.